We demonstrate the success of our stereo video see-through augmented reality system through its application to ultrasound-guided needle biopsy of the breast. Our physician colleague has successfully performed the procedure on training phantom breasts and has used the system in the preliminary stages of the procedure on a patient. Our goal is to improve upon conventional ultrasound imagery and to present to the physician a convincing, real-time, stereoscopic, three-dimensional display of the target structure correctly positioned within the breast. We generate stereo images which merge a real-time rendering of the ultrasound data, live stereo video views of the patient, and geometric elements. The images are presented to the physician in a head-mounted display. A highly accurate mechanical arm tracks the ultrasound probe. This enables us to position the rendering of the ultrasound data properly within the patient's body. 2 video cameras and an electromagnetic tracking sensor are attached to the head-mounted display. A volume is reconstructed from multiple ultrasound slices as the physician sweeps the probe across the patient. Both the cyst and the biopsy needle are clearly visible within this volume. To improve the visualization, texture lookup tables can be adjusted on the fly. The physician moves around to see the reconstructed volume from different points of view. These are the images she sees in her head mount. To generate the pit in the patient, we acquire data points by sweeping the skin surface with a mechanical arm. The vertices are converted into cylindrical coordinates and then resampled into a regular grid via an intermediate Delaunay triangulation. Finally, a polygonal model of the synthetic opening is created. The model provides three-dimensional context for the ultrasound display. Our hybrid tracking algorithm integrates a magnetic tracker with image-based tracking of color landmarks. The hybrid system provides accurate registration between real and synthetic image elements. In our real-time volumetric display, ultrasound slices emitted by the tracked freehand probe may intersect. We use a dual BSP tree algorithm to maintain the changing dataset and composite slice fragments in proper order for rendering. By drawing new slices brightly and old slices faintly, we depict decreasing confidence in the parts of the volume that have not been sampled recently. Our system is now ready for trials on human patients. The physician uses the system to locate a suspicious lump in the patient's breast. As these images demonstrate, human breast tissue produces significantly noisier echography images than the training phantom. Future work includes designing a better head-mounted display, improving the quality of the ultrasound visualization, properly handling the occlusion of real-world objects such as the physician's hands, and addressing the latency between the various input streams in our system.
The purpose of this proposal is to develop a method of frameless stereotaxy based on registration of a preoperatively acquired CT scan with an intraoperatively acquired fluoroscopic image. This is a general method, but our driving problem is percutaneous rhizotomy, an operation in which a needle is inserted through the skin of the patient's cheek into the foramen ovale at the base of the skull, as shown here. The surgeon cannot see the foramen ovale intraoperatively either by direct vision or by the X-rays obtained. One of the dangers of the operation is puncture of the carotid artery, which lies very close to the desired target foramen. Our goal is to provide this kind of display and make it available to the neurosurgeon in the operating room, so the neurosurgeon can know if the needle is aimed correctly toward the correct target, or if there is danger of puncturing the carotid artery. This is a maximum intensity projection which shows how close the carotid arteries, shown in white here, are to the target foramen, which is at the tip of the needle. The kind of display that we propose to develop, like this one, would show if the needle is aimed correctly or if there is danger. The heart of the problem is developing a method of 2D, 3D registration. We have developed a new method of registration based on bone, and this image shows the result of the registration. The correct needle is shown in white, and after registration, the estimate of the needle's position is shown in red. As you can see from a number of different views, the red needle is actually encased inside the white actual needle that was scanned. The needle is aimed towards the target, and the registration here was excellent. This general method should be applicable to a wide variety of applications, and in particular should improve the safety of percutaneous trigeminal rhizotomy. We show here the red needle, again, encased within the white structure.